Good evening. It's my pleasure to bring you the Wincars news for the month of March 2023. I'm really excited to do this Wincars news this month because we are discussing the ACC late breaking trials in this episode. I'm Dr. Asha Mahilamaran, Senior Interventional Cardiologist from Apollo Hospitals, Chennai. And it's my pleasure to bring you this Wincars news. Clearly, the clear winner and most talked about trial, which was discussed in the ACC 2023, is a clear outcome trial on bempedoic acid. The clear outcome trial design was in statin intolerant patients who had an effect that started or increased during statin therapy and resolved or improved after therapy. Intolerance to two or more statins or one statin if they are unwilling to attempt a second statin, and they do not attempt second statin, very low dose statin therapy was permitted, less than lowest approved dose. So the primary or secondary prevention patients with LDL cholesterol more than 100 milligrams per DL were randomized to bempedoic acid 180 milligrams per day or a placebo. And the key measures were four-component MACE, and key secondary component was a three-component MACE, and it was done on a 24 months follow-up. The primary and key secondary endpoints. The four-component involves non-fatal MI, stroke, coronary revascularization, or cardiovascular events. And the key secondary endpoints are three-component MACE, fatal and non-fatal MI, coronary revascularization, fatal and non-fatal stroke, cardiovascular death, or all-cause mortality. The study milestones: 13,970 patients were randomized at 1,250 sites in 32 countries, and they were enrolled between December 2016 to August 2019 and follow-up of 40 months. Despite the pandemic, there was complete assessment for the primary endpoint in 95.3% of patients and vital status in 99.4% of patients. The primary endpoint of four-component MACE occurred in 1,746 patients and three-component MACE occurred in 1,238 patients. The characteristics: the important interest is a female sex was represented in close to 50% of the population, the largest probably in representative sample. And LDL cholesterol mean was 139, HDL was 49.6, HSCRP was 2.3, high risk primary prevention was in 30%, secondary prevention was in 70%, diabetics 45%, and baseline statin use of 22%. The effect of trial regimens on LDL cholesterol, the percent change in LDL cholesterol over time. You can see that bempedoic acid resulted in a greater reduction at every stage of the study. At 6 months, there was a 22% reduction, 12 months, 20%, and sustained over the period of study of close to 19.4% at the end of study, compared to that of an increase of 2.4% in placebo. The primary and first key secondary cardiovascular endpoints of four-component MACE, there was an absolute risk reduction of 1.6% at a number needed to treat of 63. And in the three-component MACE, there was an absolute risk reduction and hazard ratio of 0.85. And the adverse events leading to drug discontinuation was not different from placebo. New onset diabetes was not higher than that of placebo. The only incidence which was increased was gout was increased marginally in the patients on bempedoic acid, and cholelithiasis incidence was about 2.2% in the bempedoic acid arm compared to that of 1.2%, and tendon rupture marginally increased in bempedoic acid as compared to that of placebo. Elevated hepatic enzymes marginally increased, not significant. Pre-specified renal events marginally increased at 11.5% compared to 8.6%. The conclusion of the clear outcome study was bempedoic acid was well tolerated in a mixed population and secondary prevention patients unable or unwilling to take statins. And bempedoic acid lowered LDL cholesterol by 21.7% and hsCRP with small increase in the incidence of gout and cholelithiasis. The primary endpoint 4-component MACE was reduced 13%, 3-component MACE by 15%, myocardial infarction 23%, and coronary revascularization by 19%. These findings establish that it is an effective approach to reduce cardiovascular events in statin intolerant patients. The next important trial which we are going to discuss is a Lodestar trial. And here it's a Korean study in about 4,400 patients were randomized to either high intensity or treat to target of LDL levels of 50 to 70 milligram per dl. And the primary endpoint was a 3-year composite of death, MI, stroke, of coronary revascularization. And the conclusion of this study was no difference in outcomes whether you treat the patients with high intensity or treat to target at LDL levels of 50 to 70 milligrams per dl. So this study concluded that it is safe to treat patients to target levels with lower level of statins if that is better tolerated, and there will be no difference in the clinical outcomes. The next trial I'm going to discuss is the Host IDEA trial. Here, shortened DAPT, whether it is safe to do so compared to that of 12 months of DAPT. STEMI was excluded in the study. The primary endpoint was the net adverse clinical events, and it was a non-inferiority trial. And here, 2013 patients were randomized to 3 months of DAPT, which was compared to 12 months of DAPT. And the primary endpoint was non-inferior to 12 months DAPT, cardiac death, target vessel MI, or clinically driven target lesion revascularization, stent thrombosis, and major bleed. It was a 3 months DAPT was non-inferior to a 12 months DAPT. So it is safe to do so in a high bleeding risk patients, that you can shorten the DAPT provided you have excluded the STEMI, was the conclusion of this trial. Next trial I'm going to discuss is the Renovate Complex PCI trial. This is an imaging versus angiography guided complex PCI. Intravascular imaging, you could use either an IVUS or OCT. 75% of the study had IVUS and 25% had OCT. An intravascular imaging based approach was tried in more than 1,000 patients, and 547 angiography guided approach was compared. And the composite, the target vessel failure was 8.7% in the angiography guided group compared to that of 5.1% in the imaging group. And the composite of cardiac death, target vessel MI, clinically driven target vessel revascularization was 12.3 in the angiographic group compared to that of 7.7% in the imaging guided group, giving a clear indication that imaging guidance improves the clinical outcomes in patients with complex PCI. Next is a BioVasc trial. This is a trial whether an immediate revascularization was non-inferior to a staged multivessel PCI. This was the objective of this trial. And what this trial found that an immediate complete revascularization was non-inferior to the staged multivessel PCI. And there was a reduction in the spontaneous MI, and there was a reduction in unplanned revascularization in the immediate complete revascularization compared to that of staged multivessel PCI. So an immediate complete revascularization approach was found to be safe and superior in reduction of spontaneous MI and reduction in complete unplanned revascularization, but there was no difference in the clinical outcomes at the end of the study. The next trial I'm going to discuss is STOP-CA trial. In this trial, patients with lymphoma on anthracycline, statin versus placebo was tried. whether statin is going to be protective against a cytotoxicity of the anthracyclines and drop in ejection fraction. And the conclusion of this trial was that statin was 3 times less likely to cause a more than 10% decline in EF less than 55%. So use of statin can proactively prevent cytotoxicity to the heart and prevent an ejection fraction decline was the conclusion of the STOP-CA trial in patients with lymphoma. Lastly, I'm going to discuss the revived BCIC2 viability study. This is a study which was done to assess whether a viability study in patients with LVEF less than 35%. The viability assessment was done with vitamin stress echo, MRI, SPECT, or PET. And based on these modalities, you can attempt to find out whether PCI versus an optimal medical management was a superior effort. And the conclusion of this study was that PCI versus optimal medical treatment, there was no difference across the subgroups, whether the LV was viable, non-viable, or partially viable. There was no difference in the outcomes, whether it was PCI versus optimal medical therapy. One of these important outcomes which came out in this study was scarred myocardium gave a greater prognostication rather than the viability factor. If the scarred myocardium was more than 10%, it was associated with worse prognosis irrespective of the viability assessment. So scarred myocardium seemed to carry a greater prognostic value rather than a viability assessment. And based on viability assessment, PCI or optimal medical therapy may not really yield the appropriate results, was the conclusion of this study. Thank you.
Good evening. For this month's Wincars news, myself, Dr. Sridevi, cardiologist from Pune, will be presenting clinical trials which were presented in ACC 2023. First trial is TriLuminate trial, transcatheter repair for patients with tricuspid regurgitation. The aim of this trial was to evaluate tricuspid valve transcatheter edge-to-edge repair compared with medical therapy in patients with symptomatic severe agitation. The conclusion of this trial was tricuspid tear was safe for patients with severe TR, and it reduced the severity of TR and was associated with improvement in quality of life, but there was significant reduction of the hard endpoints like major adverse cardiac events or hospitalization for the heart failure. Coming to the FLAME trial, FLAME was flow driver for acute massive pulmonary embolism. The aim of this trial was to evaluate the efficacy of float river in patients with high-risk pulmonary embolism treated with mechanical thrombectomy. The conclusion was this trial was stopped prematurely because patients who were treated with large bore mechanical thrombectomy with float river was associated with significantly lower occurrence of in-hospital adverse clinical outcomes and lower rate of mortality. Third trial is the AID-U trial, macitentan tadalafil fixed combination in pulmonary arterial hypertension. The aim of this trial was to compare safety and efficacy of macitentan tadalafil combination therapy compared to macitentan and tadalafil monotherapy in patients with pulmonary arterial hypertension. The conclusion of this trial was fixed dose combination with macitentan tadalafil is superior to monotherapy in reducing pulmonary vascular resistance at 6 weeks in patients with pulmonary arterial hypertension. Coming to the other trial, oral PCSK9 inhibitor MK0616 trial. It is a phase 2B randomized controlled trial. The aim of this trial was to evaluate safety and efficacy of MK0616 in patients with hypercholesterolemia. The conclusion of this trial was oral inhibition of PCSK9 with MK0616 at different doses varying from 6 mg to 30 mg daily provided clinically meaningful reduction of LDL cholesterol and it was superior to the placebo in patients with hypercholesterolemia with a wide range of atherosclerotic cardiovascular disease risk and background statin therapy. Further, all doses of MK-0616 were well tolerated with lower incidence of severe adverse events. Adverse events and discontinuations due to adverse events were similar to that of placebo. Trial, patients with heart failure with reduced ejection fraction were randomized to the patiromer for management of patients with hyperkalemia. The aim of this trial was to evaluate patiromer compared to the control among patients with heart failure with reduced ejection fraction who had a history of hyperkalemia. The conclusion of this trial was among patients with heart failure with reduced ejection fraction and history of hyperkalemia, patiromer was beneficial and it was able to maintain lower serum potassium levels and it was associated with lower incidence of severe hyperkalemia compared to the control group. And this drug allowed for 85% of patients to be optimized on guideline-directed medical doses of renin-angiotensin system inhibitor. Coming to the target FFR trial, this is the trial of angiography versus pressure ratio guided enhancement techniques. The aim of this trial was to evaluate physiology-guided incremental optimization strategy compared with usual care among patients who underwent primary percutaneous coronary intervention. The conclusion was among patients who underwent angiographically successful PCI, physiology-guided incremental optimization failed to improve the proportion of patients with an optimal result, that is FFR more than 0.9. The possible explanation for the lack of benefit from physiology-guided incremental optimization is that optimization was only attempted in 31% of patients. And a physiology-guided incremental optimization strategy was associated with decrease in suboptimal result, that is less than 0.8. So appropriately powered randomized trials would be required to evaluate whether physiology-guided optimization is superior to the normal angiography-guided strategy for PCI. Coming to the STELLAR trial. This is the phase 3 trial of sotatercept for treatment of pulmonary arterial hypertension. Sotatercept is an inhibitor with arterial remodeling. And the aim of this trial was to compare the safety and efficacy of sotatercept on top of background pulmonary arterial hypertension therapy among patients with symptomatic PAH. The conclusion of this trial was treatment with sotatercept improved exercise capacity as determined by the 6-minute walk distance and showed clinical benefit across multiple efficacy endpoints. So sotatercept had a favorable benefit-risk ratio. So all these trials, they were discussed in ACC 2023. Thank you.